rounds for the Department of Behavioral Medicine and Psychiatry. Huge pleasure to welcome back our own Joy Parks today. Very nice to see you again, Joy. It's been a while since you were here with us for residency. Dr. Parks got her BS and XPhys actually from WVU, went on to get an MD from our own institution and complete a psychiatry residency back in June of 2022. She's now serving as an assistant professor, in the clinical track here, based mostly out of Sharp, which is our state hospital down in Weston. She is currently also serving as a membership chair in the State Psychiatric Association, on our P&T committee for medications, and as an ethics committee member for Sharp as well. Dr. Parks achieved numerous awards during her time here involving excellence in academics, clinical psychiatry. She's presented on several topics, including things related to today's topic, as well as legal issues, intellectual disability, gender diversity, and catatonia. She has some non-clinical experience dating back to serving as a STEM ambassador, which I thought was very nice to give back to our local community. So quite a pleasure to welcome Dr. Parks back for her topic, Hiding in Plain Sight, Autism in Females.
All right, thank you so much for that introduction. Are you able to hear me?
Sounds good to me.
Okay, I have to figure out the sharing thing. Unless it's already doing it, but I doubt it.
Don't think it is yet.
Maybe this button. And then that. Maybe.
Yeah, it's looking good.
Can you see that?
Yep.
Is it the right view?
It's the right view.
Perfect. All right. And so gonna get started. Thank you so much for that introduction. It was lovely and it's good to be back presenting, as you said, on autism in females, hiding in plain sight. Disclosures, I have no disclosures to report, maybe someday. Disclaimer, so much of the research on autism in females has thus far been focused on cisgender females. And while this presentation will be discussing distinctions of how autism presents differently in females, this does not mean all females will present in this manner, nor that other genders may not have similar presentations. So I feel it's important to start with that caveat. Learning objectives. Following this presentation, participants will be able to discuss how the concept of autism has evolved over time, utilize depathologized language when discussing autism, identify the core features of this condition and how they present, discuss the male bias in autism research and diagnosis, identify ways in which autistic women present differently than males, identify unique challenges autism can pose for females, and find information and resources on how females can successfully navigate autism and thrive. And so going over the evolution of the term autism itself. So this initially was coined by Bleuler. He was the author of Dementia Praecox. He coined it back in 1911 to describe one of the symptoms in schizophrenia. In 1943, Leo Kanner, pictured in the corner, developed the concept of inborn autistic disturbances of affective contact, which he used to describe a subset of the children that were his patients that he identified as having obsessiveness, stereotypy, and echolalia. In the 1940s and 1950s, schizophrenia, autism, and psychosis in children were all pretty much used interchangeably. But in 1971, Colvin identified that there were distinctions whenever you compared patients with early onset psychosis versus those with late onset psychosis. And so he argued that gazing around in a distracted manner or looking as if they're hearing voices is insufficient. The child must have given the account of auditory or hallucinatory phenomenon. And so there were assumptions going on, and he challenged that. And so in 1980, the DSM-3 was published, which it provided criteria and added the diagnosis of infantile autism specifically with criteria for that. In 1994, DSM-4 was published and gave us the diagnosis of Asperger's disorder. Since then, in 2013, the DSM-5 came out, which combined several different diagnoses, including Asperger's disorder, among others, under the overarching umbrella term of autism spectrum disorder, shorthand ASD. And so going over what the criteria are, essentially between the DSM-5 and the TR, the criteria in essence stayed the same. Only real change was that for criteria A, they explicitly specify that it's as manifest by all of the following instead of just manifest by the following. But essentially, criteria stayed the same. And I don't know of anyone that was diagnosed that didn't meet all of criteria A. They just felt the need to specify that. And so autism spectrum disorder involves a combination of communication deficits as well as repetitive behaviors and restrictive interests. And so for the social communication deficits, they need to have all of the social emotional reciprocity, which that's the ability to share thoughts, feelings, and ideas and engage with others. Often in autism, there can be an expressive language that forms a lot earlier than the receptive language. And so individuals sometimes, while we might think of delayed abilities to verbalize and such, sometimes there's actually precocious ability to speak in large terms and such, especially in females, which historically might be overlooked, but large words, but then whenever they're asked questions or whatnot, not necessarily understanding what is being expressed, can also impact the ability to engage with. If it's not someone's special interest, then they might be less inclined to engage in that manner. For nonverbal communication, that can involve a lot of different things. So eye contact, things like clearing the throat, which people might not perceive has communicative meanings that for those that are autistic, but to neurotypical individuals can be interpreted that way. For relationships, there's often difficulty with developing, maintaining, and understanding, which that's one of the 4 criteria. Regarding that, there's a common misconception that autistic individuals don't want to have friends or they're content to be alone. Oftentimes, they do want friends, they just don't know how to go about getting them and maintaining those friendships. As far as the receptive behavior and restricted interests, requires 2 out of 4 to make the diagnosis. And so that involves repetitive behaviors, which can be repetitive speech, body movements. Sometimes that can be things like rocking, but it can also be spinning objects or finger flicking or things like that. Or repetitive behaviors with objects. Sometimes people, girls may carry around a baby doll, but not really interact with it, more so just carrying it instead. Insistence on sameness or ritualized behavior. Oftentimes, it can be difficult with transitions and changes from the schedule that can cause a lot of distress. And so often individuals may pick the same type of food or different things that are more familiar and less novel to reduce stress. This can sometimes manifest as eating disorders, which can sometimes be something that's identified and then autism overlooked. Fixated or intense interests. These often present differently in females versus males, and then sensory differences. And so that can be sensory sensitivities. It can also be hyposensitivities. Someone might have a lot of difficulty with certain lighting, but they might not respond to their name sometimes, or might lighting and sound are often problems for folks. Additional criteria: the symptoms per the DSM must be present in the early developmental period, but may not become fully manifest until social demands exceed limited capacities or may be masked by learned strategies in later life, which this is a big thing in females. Oftentimes, they can exhibit what would be considered within the normal distribution for a time, but then once they get further along in life, maybe adolescence, maybe further, it can become more difficult to navigate that. Which, on that topic, if someone's maybe assessed really young, they might not have gotten to that point where the demands have reached that. And so sometimes it's worth reevaluating, even if they have had a prior evaluation, because maybe they now are at meeting criteria. And then, of course, there's the impairment and not due to another condition, though, is often comorbid with many things, especially IDD. And so regarding body language, eye contact in particular isn't inherently intrinsically something that autistic people will understand or do. However, this is something that can be a learned behavior where they can either make or pretend to make eye contact. This does tend to be distracting for the individual and can have an emotional impact. So it can cause the individual to become more stressed, or they could get exhausted and need time to recharge later. I've discovered in talking with individuals with autism that if I express that they do not have to make eye contact, often it'll drop considerably or sometimes down to essentially zero, but often they can communicate more effectively in that manner. And so something to consider. There's the double empathy problem. And so people tend to conceptualize that the problem is with autism itself, but more so the interplay between people with autism versus those without autism. And so autistic individuals may struggle with reading between the lines, overcoming other people's misconceptions about autism, and managing sensory distractions. Conversely, non-autistic people can have difficulty with forming positive first impressions of autistic individuals. This is more so if they're in person, when they look at online communications where there's not that body language component and intonation and those components, that tends to be mitigated. Recognizing and understanding autism, there are a lot of misconceptions out there. And then imagining autistic sensory difficulties. Both parties can struggle with understanding each other's thoughts, feelings, behaviors, and differences. Whenever autistic individuals interact with each other, this isn't really a problem. It's more so the interplay between the two due to their differences. And so going over the language and words that we use. So a frame of reference: imagine a patient presents with the following symptoms: over-reliance on eye contact, might make intense gaze, using nonspecific facial gestures to communicate feelings, expecting others to understand what they're trying to convey without being explicit, hyposensitive to the environment with limited responses to sensory input, having a wide range of superficial interests despite lacking the persistence to develop a deep knowledge of that which they're interested in, and tending to be overly spontaneous, lacking consistency in their day-to-day behaviors. So what is the diagnosis? Holistic. And so from an autistic perspective, this is kind of how other individuals can seem, and so that can be very confusing, especially if one does not understand but they're different. And so allistic is a term meaning non-autistic person. Neurodivergent is another term. It's an umbrella term for when a person's brain processes, learns, and or behaves differently from what's considered typical. This includes diagnoses like ADHD, autism, dyslexia, dyspraxia, and other learning disabilities. Some sources also incorporate neurologic or psychiatric conditions in addition to the above. Within the autistic community, neurotypical is often used to describe someone that is not autistic. And so the autism spectrum, people tend to think of it as a linear of less autistic versus very. It's not, in fact, that way. So there's several different dimensions. And so someone might have better or worse social skills or more or less routines or fixations or difficulties with executive functioning, etc., which this can be impacted by the setting, more novel situations, or if someone is tired or stressed, they might have more difficulties, and that may come out more. In the DSM-5-TR, as well as the prior iteration, the DSM-5, the severity is based on the amount of support required, and so there's 3 different levels based on if it's low support needs versus high versus very high. Multiple self-advocacy groups have advised against the using of functional labels, and so words like low functioning and high functioning, they advise against, which the organization formerly known as the Asperger Autism Network has since been renamed. They had explained that using the terms such as high or low inevitably diminishes the needs of one group while ignoring the abilities of the other. Personalities, aptitudes, and sensitivities exist along many spectrums on multiple dimensions. And then as far as the use of the word disorder, there's been a shift away from that in the research. Many articles now call it autism spectrum condition, autism spectrum, or just the word autism by itself to describe it. Baron Cohen in 2015 expressed that the term condition still succeeds in signaling that autism is biomedical, entails disability and vulnerability, and thus can serve as a trigger for services, whilst acknowledging both cognitive deficits and assets, in short, a different cognitive style, which condition more so a state of being, whereas disorder, meaning being lack of order or intelligible pattern, which can suggest something's broken. An example of other conditions in which the term condition is used is heart condition, and so can be beneficial to use the other terminology. And just looking at PubMed the other day over what's been used over the last 5-ish years, if specifying for titles that contain the word autism, but leave out the word disorder in the title or abstract. There's quite a few that do that. And so looks like over 4,000 results over that time frame. And then identity versus person first language. So identity first language would be things like autistic person, woman, or autistic man, generally preferred within the autistic community, whereas the person first language is things like person with autism, woman, man with autism, or sometimes it'll use other things like suffers from or on the spectrum. And so those suggest that autism is separate from the individual, whereas the autistic community recognizes it as an integrated part of themselves that impact how they perceive and live in the world. And so here we have a poll that someone had done on a, I'm assuming, social network website on what people preferred. An autistic person was much preferred in that. And then people who are autistic often take pride in that. And so this comments on cannot be separated from how we are as people. Calling ourselves autistic is a declaration of pride. And so a lot of people are proud of the autism diagnosis. And so contrary to what historically people would think, there's a lot of pride that people can have with that. And so reconsidering how we speak about the difficulties people have. And so social skills deficits could be instead termed social skills differences. Restricted interests could be reconceptualized as detailed interests. Rigid or inflexible could be reconsidered as valuing consistency. Non-functional routines or behaviors used to cope. I erroneously forgot to remove the image from the prior slide. But here we have Temple Grandin. She has a PhD in animal sciences and has written numerous books on that, as well as on autism, has done multiple studies. And she famously said, "I'm different, not less." And so the rates of autism per the CDC, they keep active monitoring of the children that are age 8 in the 11 sites, noting that West Virginia is not one of those. They've been tracking what the frequency is in the children in general, and then breaking it down, male versus female, and it also breaks down into different ethnic groups. And so the most recent study, which was based on the data from 2020, indicated that 1 in 36 children have a diagnosis of ASD. And so this is, again, children at age 8. And so if they were diagnosed later than that, would not be included in this number. This is the most recent value. Generally, there's a delay of 3 to 4 years between the data and their ability to put those numbers together and crunch those numbers. They found that boys are 3.8 times more likely than girls to be diagnosed. And the changes in the ratios over time and prevalence is in part due to increased frequency of girls being diagnosed. We are getting better at diagnosis in general. Some of the minority groups we're getting better at as well. And so this is just across time, how the percent prevalence, so percentage of people that are diagnosed has increased. So back in 2000, it was 1 in 150 kids, and then has steadily risen up to the current amount. And so essentially that's 4 boys to every 1 girl being diagnosed with autism. And so a considerable discrepancy between the two reasons that can contribute to this. There is a male bias in research. And so kind of in general across research studies, there tends to be preferential selection of males, often because it takes out the concerns of pregnancy and often can be easier to find those populations, often better data on that. But essentially, in clinical practice, we're under recognizing and failing to diagnose autistic females, which consequently, given they don't have the diagnosis, they're not getting into the research studies. Additionally, females who do get the diagnosis often have co-occurring conditions such as epilepsy or low IQ, which often are things that result in being left out of the studies. And so they're already misrepresented for the research. And so when we get to the knowledge translation and interventions, there's more so information for the males, and so application is primary based on that male-based understanding. Diagnostic rates in the 2015 study, male versus female ratios of autism diagnosis varied based on cognitive profile. This does continue to be the case, albeit I imagine the numbers have changed somewhat since then. At that time, 4-to-1 male to female ratio for receiving the autism diagnosis, whereas it's 2-to-1 for male versus female among children with intellectual disabilities. And then for those with low support needs, the numbers far more vast, 5.7 to 11 versus 1 for male to female ratio in those low support needs. When assessing the general population of ASD, regardless of the pre-existing diagnosis, the ratio drops down to 3-to-1, and so this indicates that there's a lot of girls meeting current diagnostic criteria that are being underdiagnosed and unrecognized. Misdiagnosis and delays. Autistic females with average or above average IQ do tend to get diagnosed later in life than their male counterparts. One of the studies found that among the adults that they looked at that were diagnosed with autism without language or intellectual impairment, that there was an 8-year delay between when they were referred for mental health services versus when they ultimately received the ASD diagnosis. The average age also was different, and so for females, referred at 21, but not ultimately diagnosed until 29, and then for males, referred at 12, diagnosed at 20, respectively. And so this was just in the one study, so not across the board. But in the study, female misdiagnosis was at a higher amount, with 50% in females, 20% in males. Common other diagnoses that people get are anxiety diagnoses, depressive diagnoses, eating disorders are very common. OCD also common. ADHD often runs with ASD, and so there is a lot of overlap with those different conditions. And so sometimes it's that they're comorbid, but sometimes it's just that we're missing it. There has been theorized that there might be a female protective effect, which would suggest that more environmental and/or genetic risk factors for autism would need to be there for it to manifest in females. It has been noted that spontaneous mutations, i.e. those that are not inherited, are found more frequently with autistic females. There's a greater risk factor requirement that would suggest relatives of autistic females would be at a greater likelihood of having autism or autistic traits compared to autistic males. Studies have been mixed on whether or not they support this, though, and no specific protective factors have been identified. And so regarding underdiagnosis, several studies have looked at it and identified that females often go undiagnosed, misdiagnosed, or receive delayed diagnoses. This was from a study on different themes of late diagnosed women. And so it involved, I believe, 14 women that they interviewed to find out common themes. The thinking with that study was that if we're missing a large segment of the population, then the people that are diagnosed later likely have those findings that we're missing. Can also be informative as far as people that we have missed, what can happen if we fail to make a diagnosis. And so a really common theme in the study was that people were told they weren't autistic, and so they were labeled with other diagnoses. As we'd mentioned before, that's a common thing. There were unhelpful stereotypes that had led to it being missed, and so some of the people would only recognize if there was severe social impairments. And so if there was, if the female showed some capacity, even superficial, to socialize with others, it was often dismissed as a potential diagnosis. There's also a stereotype historically of people thinking more so of Rain Man and the need for savant type skills or having to be interested in math or science. And so people not fitting that particular manifestation being missed. Oftentimes quiet at school, so went unnoticed. Females in general, across many diagnoses, tend to be more apt to internalize, and so they tend to be hard on themselves as opposed to acting out. One of the participants in the study stated that she should have burnt more cars so that she would have been diagnosed earlier. Often misunderstood, unsupported, or blamed by teachers, and so there were instances where the people in the study expressed that they notified their teachers of being bullied and they were told that it was their fault and they needed to act more normal, or that they were egging the bullies on when in fact they were just being themselves. Gonna discuss masking and social mimicry in a bit. Can find themselves in abusive relationships or risky situations, don't necessarily pick up on when situations might be headed that way, don't necessarily have as strong of friend connections to give them that knowledge of how to stay safe, and so can be victims of sexual abuse. In the study, 9 of the 14 women had been the victims of sexual abuse. Factors that impacted that is that many were unaware that they could say no. And then among those that were aware, several of them didn't know how. And so having kind of an idea of what to do in that situation ahead of time can be really helpful. About half of the individuals, it occurred in relationships, though did occur for some with unknown individuals to them. And then, sorry. Regarding identity, there's different social pressures among young women. They're expected to be more social in their interactions generally. For friendships, it can be difficult, especially with neurotypical girls. They don't necessarily have the same interests, and peers can pick up on the subtle differences even when teachers might not. Often finding it easier to be friends with boys, given there's less of the social element in terms of sharing of emotions and such. And then friendships and support online has been something that autistic women tend to find helpful. So going on to social mimicry, this is an automatic, unconscious response that autistic individuals have. And so this can involve things like copying speech patterns or body language. They might copy intonation. Several of the individuals in the study expressed that they would be quick to pick up accents. And so this isn't intentional, and they weren't necessarily aware that they were doing it until it was pointed out to them later. But that is one of the things. It can have the potential to feed into the risk of unhealthy relationships or sexual abuse, and that if someone's engaging unintentionally in social mimicry, if someone is being flirtatious, they might inadvertently be mirroring that back to them without realizing. Masking, conversely, is willful and conscious. And so females may portray a different persona when around peers to suppress the autistic traits. This is emotionally draining, however, and can lead to meltdowns, need to recharge. As far as ways autistic women find to learn this, sometimes they'll get it from reading books, watching TV, watching movies, observing how others interact, and trying to mimic this to fit in better. Autism in the media historically is primarily males that have been presented. And so there's Rain Man, which had more of the savant, great math skills, would have been associated with Asperger's. Well, as far as the savant aspect, back when that was a diagnosis. Fantastic Beasts for Newt Scamander, while not explicitly stated, his behaviors do tend to be consistent with what you would see with autism. Love on the Spectrum, this is a newer show somewhat, that involves autistic relationships and so does portray both females and males. Atypical has a male protagonist. On the Spectrum and Sesame Street did create a character, Julia, that's female, and demonstrates some traits like flapping. They had recognized that there weren't too many portrayals of females, and so they created one. Social camouflaging is a hypothesis for the differences in diagnoses. For autistic females, they may be more apt to develop the social skills and coping mechanisms that will allow them to blend in or camouflage themselves into society. And so this can lead to them being missed. It can have social scripts. And so an instance that one of the associate professors at UCSF encountered was one 6-year-old girl I met several years ago seemed at first to have good social skills. She responded appropriately when I introduced myself, complimented my outfit, and politely answered all my questions. It was only when I saw her again a few days later that I understood her family's concern. She made nearly identical overtures as if our interaction were part of a play she had rehearsed. And so often going back to what they've learned as far as normal interactions, but having difficulty with that flexibility in different situations or whatnot. Imaginative play is one of the things that's often asked about to the parents when trying to assess a diagnosis is warranted. And so parents may report that their daughters engage in pretend play, but if you dig further, it's often more scripted or repetitive in nature. It might be replaying conversations that they've overheard or things that happened at school. And so less of the typical imaginative play you see. Conversely, some autistic women are especially creative and can have very lively fantasy worlds, not a psychosis, but more so kind of pulling back from difficult interactions to engage that way. All right, socially acceptable interests. So in males, you more so see the interest in trains or math or science. In females, oftentimes their interest can seem on the surface to be normal, but it's more so that intensity and focus that is the difference. And so might be especially interested in horses or other animals, like cats. But whenever it comes to speaking of other topics, it might be really difficult and impairing for them to switch. Might be really interested in fantasy in terms of makeup. They may be interested in makeup, but it's sometimes more so having a collection of the various products or being able to have that sensory experience of the brush on the face, or the artistic expression of getting to try different designs, as opposed to what neurotypical individuals associated with that. Sometimes it's the Disney princesses. That said, there is a degree of it being typical for young females to want to watch their favorite princesses multiple times. And so taking into consideration the age, gender, and what's socially normal when assessing. Art's often an interest. Individuals might be interested in people, possibly Taylor Swift. And so instead of what would be more so the neurotypical interest, it might be more detailed things like wanting to know where the person went to school or how many significant others they've had, what their favorite color is, their favorite ice cream. So a far deeper interest in and such than what would otherwise be deemed typical. Other differences in terms of social, females tend to exhibit more advanced emotional, interpersonal, and social skills, being able to recognize emotional states in others better, prosocial behaviors like comforting others and perspective taking. I suspect that this has to do with females tending to be tends to be more acceptable for females to discuss emotions as opposed to males. And so having that knowledge, I think, is part of what helps with that. Women's health. And so females, of course, go through the different women's health transitions. For puberty, there can be a lot of sensory challenges that impact things. It can occur earlier than one might otherwise expect. Hygiene and self-care can sometimes be difficult in part due to those sensory challenges. And so one of the studies looked at knowledge that parents felt the children had and their ability to address hygiene, and found that the sensory challenges could be a barrier in terms of using menstrual pads. Might want to use alternative options in those situations. The study, this Arslan et al. In 2024, there was a paucity of information of the parents educating their daughters regarding what to expect and how to prepare, what changes were coming for puberty. And so being educated on that before it happens is really important. And so we can't necessarily rely on parents to do that, and they don't necessarily know when that's going to be. And so as clinicians, it can be helpful to guide that conversation or give parents an idea and support on how to do that. Other things associated with puberty: body odor, body hair, such as the underarms and legs, if not addressed, can have adverse social consequences. And so making sure that there's education and that the girls know what to do when that starts. It's really important. For motherhood, can also be a challenge, but sometimes can be beneficial in that some autistic individuals have better memories of their youth, and so can better remember what it was like to be their child's age, and that can be beneficial in their ability to engage and see things the way their child does. That said, executive functioning difficulties can make it difficult in terms of things like organizing playdates for their children. For heritability, there is a fair amount of heritability with autism, and so if one member of the family is autistic, the probability of another one being autistic also is increased. And so that can have its own challenges. And then menopause is also difficult for autistic individuals, though hasn't been studied as much given our historical underdiagnosis of women. Risk of precocious puberty, and so that's premature development of secondary sexual characteristics before age 8, is increased with women, well, females with autism. So is about 2 for the adjusted hazards ratio, and then even more so if you took into account the other factors, which the relative excess risk was about 8, which for that other factors for ADHD, which is the biggest one, tics, OCD, anxiety disorder, intellectual disability, and epilepsy all also impacted that. That said, the percentage is still fairly low of how often it happens, but does occur more so. And so making sure to prepare people ahead of time. Risk of self-harm in the autistic population is elevated. And so overall, for children and adults, it was around an odds ratio of 3 for self-injurious behaviors. Suicidality was also rather high for the children. Suicidality with an odds ratio of 2.5, and for adults, 3.8. So making sure that you're taking that into consideration. That is, of course, impacted by comorbidities, but seems to be greater even when taking that into account. When you consider autism among the gender diverse individuals, it does tend to impact people that are of other areas on the gender diversity scale. And so cisgender females, common, and then cisgender in general, but does happen with transgender individuals as well. There's been several self-advocates that have told their stories with various ages of diagnoses. Sarah Hendricks, diagnosed at 43. She had written several books on autism before ultimately being diagnosed herself. There's the Spectrum's Girl Survival Guide, which the author of it was diagnosed at 12. Autism in Heels, the author was diagnosed at 35. Odd Girl Out, author was diagnosed in her 40s, at which point she was already married with 4 children and a successful journalist. Temple Grandin was diagnosed at age 3. She had the more typical presentation of what we tend to think was nonverbal until 4, but did ultimately develop her abilities and is a professor of animal sciences at Colorado State University. So making sure that you don't discount people just because they're having difficulties, they can still be very successful. Other advocates, the author of Nerdy, Shy, and Socially Inappropriate was diagnosed at 42. She was a chemical engineer. Asperger's on the inside. The author was diagnosed at 30. She's a chemical engineer. Everyday Asperger's. Not sure of the diagnosis, but the author has a master's degree in education. And then there's compilations of writings by autistic women. And so Spectrum Women, as well as Asperger's, are both compilations of several writings by women with autism. There's also a video adaptation for Temple Grandin. She very much wanted the person portraying it to properly portray what an autistic meltdown is like, and they did a really good job of portraying that and sensory sensitivities, and so I encourage you to check it out to better understand. And then this is a resource that can be really helpful for whenever females are approaching or in their preteen, teenage years. Does discuss things about puberty as well as safety, among other things. And then there's various self-advocacy groups, the Association for Autism and Neurodiversity, Autistic Women and Non-Binary Network, and the Autistic Self-Advocacy Network. I open the floor to questions.
This is Dr. Vogt. I was going to ask a question about kind of the role of neurology in evaluating these patients. I know that the risk of seizures is higher in these patients, and maybe some other things. You care to comment on that?
So it is more frequently diagnosed in the individuals that have epilepsy or intellectual developmental disorder. And so considering that in the diagnoses, and if the symptoms seem to be there, doing a referral for further evaluation can be beneficial so that we get these girls the support they need early.
I don't know if you can see the chat, Dr. Parks. We're getting some questions in there.
I'm trying to figure out how to find it.
Just go ahead and read them for maybe Chris.
That would
Yeah,
be
sure.
perfect.
We have one from Dr. Hirschler. He asks, what do you think of the idea of opioid tone being etiologically related to autism? High opioid tone being a cause of autism, while low opioid tone being the cause of fibromyalgia.
That's not really something that I've looked into, and so I unfortunately can't really speak on that.
Kind of going off of Dr. Vogt's question, Dr. Parks, do you have any thoughts about like how much or how little a neuropsychological evaluation adds to the diagnosis of autism?
So it is a clinical diagnosis, and especially with females, a lot of our tools that we use to make the diagnosis are based on the male lens that we've historically used, and especially when it comes to considering the social mimicry and especially social masking that can certainly impact the results. And so it has been suggested that things like the ADOS might not be as sensitive in picking up on autism. And so more longitudinal views and in more naturalistic settings can be beneficial. Which not over relying on any one component is beneficial. Which when you think about it, a lot of the time we ideally get information from the parents, but given the heritability, they might perceive things as within the norm because it might be how things are done in the family, but that might not be consistent with what is or is not the typical for others.
Thank you, that's helpful.
There are other things like the autism quotient, which has been validated in females, that can be used to help information-wise or as a screener, to give better idea, which that's accessible on the public domain. It's Googleable. there more in the chat?
Richie says, thanks, I took a lot from this.
I still can't figure out. Oh, wait. Found it.
Well, I think we're just about at time if unless anyone has another really quick question. So otherwise, thank you so much, Joy.
All righty. Thank you. Take care. Bye.